Give me a minute. Just live streaming YouTube also before we go live. Give me a minute. Yeah, we go live now.
Hearty, you want to listen to this? Pull up your chair.
Respected seniors, teachers, faculty members, and delegates. Greetings from IAP Neocon 2021. I am Dr. Jobe, President, Thrissur Neonatology Forum. Let us start the 33rd webinar of Learn from the Legends, International Bi-monthly Webinar Series, an academic initiative of IAP NeoChap, which is organized by NNF Kerala and IAP Thrissur. We have nearly 7,000 registrations from 75 countries for this academic feast. A warm welcome to all the delegates in Zoom platform as well as YouTube channel on behalf of IAP NeoChap. Today, we have an eminent faculty, Professor Dr. Jobe from University of Cincinnati, USA, to address on an important topic, antenatal steroids, an update. We welcome you, sir, for this webinar. Two senior experts in neonatology of our country are moderators for today's session. Dr. Rahul Verma from Mumbai and Dr. Rama Chandramohan from Chennai. Hearty welcome to both of you to the webinar. Now I request Dr. Manoj to introduce the chief guest.
Am I audible?
Yes.
Hello everyone. Professor Jobe graduated from Stanford University with a degree in biology in 1967. He then completed MD and PhD degrees in 1973 at the University of California, San Diego. His PhD research was on regulation of LAC operon with doctors Melvin and Suzanne Cohn at the Salk Institute. During medical school, he also directed a free clinic for the Flying Samaritans 1 weekend each month in Baja, California, Mexico. Dr. Jobe joined the Department of Pediatrics at Harbor, UCLA in 1977, where he became a professor of pediatrics at UCLA in 1983. He became director of perinatal research laboratories at the Walter P. Martin Research Center in Harbor, UCLA in 1995, and he was named the first Joseph W. Senjean Jr. Professor of Pediatrics at UCLA in 1995. Thereafter, he moved on to Cincinnati Children's Hospital, University of Cincinnati in 1997, where he presently is Professor of Pediatrics in the divisions of Neonatology and Pulmonary Biology. Actually, friends, it's a proud moment for me to introduce Professor Jobe. I had the fortune to hear his lectures a couple of times at Singapore, Bangalore, and some other places, and I have never stopped admiring this great legend ever since then. If I am going to read his bio sketch completely, it's going to take up considerable amount of time. So let me just only mention the key points that kept on increasing my admiration for this great legend of neonatology of all times. Professor Jobe has been instrumental in FDA approval for surfactant therapy for the treatment of RDS because of his many original metabolic and physiologic studies. His research interests are in fetal inflammation, surfactant homeostasis, lung development, lung injury, and bronchopulmonary dysplasia. Professor Jobe has continued research funding since fellowship, and he was the director of the P50 program project grant from NIH LBI to study surfactant homeostasis in transgenic animal models at Cincinnati Children's Hospital and Medical Center. He has worked for 27 years with NIH and Australian NHMRC funding in Perth, Western Australia and Cincinnati on translational research to understand the fetal lung maturation, fetal inflammation and the risk of bronchopulmonary dysplasia. Friends, we already know that he is one of the authors for the concept of new BPD, which we see and try to understand these days. He had also participated into clinical studies funded by the NIH LBI to evaluate chorioamnitis and lung outcomes in late preterm infants to identify the biomarkers for bronchopulmonary dysplasia. He was the chair of steering committee for NICHD Neonatal Research Network from 1996 to 2006. He served on the NIH Human Embryology and Developmental Studies section from 1983 to 1987. He was a member of the National Advisory Child Health and Human Developmental Council for NIH from 2003 to 2007. He was also the chair of the steering committee for NICHD Global Research Network and a consultant to Fundazim has been, I hope I am pronouncing it right, a research foundation on Argentina. Our friends from Argentina, please excuse me if I pronounce it wrong. He presently is a consultant for Bill and Melinda Gates evaluations of maternal and infant mortality. His CV lasts over 400 peer-reviewed publications and over 220 editorials and chapters and other publications which we study now. His service to academic pediatrics also include being SPR Council member from 1984 to 1988 and SPR President in 1989. He was an editor for pediatric research from 1984 to 1988 and was an editor for J Pediatrics from 1997 to 2016. He organized many training seminars for young pediatric faculty in Estonia, Poland, Hungary, and many other places for the SPR, APS, ESPR in 1993 and 1993. As a young student in 90s, I remember we used to hear about this legend even then. Other activities of his include reviewing grants for the Basil O'Connor Awards for March of Dimes. Professor Jobe received the Rose Award in Research from the Western Society for Pediatric Research in 1984 and the E. Med Johnson Award for Pediatric Research in 1986. He has received the George Zimbrunner Lecturing Award at the New Frontiers in Neonatology in Innsbruck, Austria in 2005. Professor was elected to the Institute of Medicine, National Academy of Medicine in 2007 and he gave the prestigious William Silverman oration at the PAS meeting in 2009. Professor Jobe has received the Thomas Helsinki Distinguished Service Award from the Society of Pediatric Research in 2010. He was recognized by the LA Biomed at Harbor UCLA Medical Center as a legend for service to Harbor UCLA. He received the prestigious Virginius Abgar Award from the AAP in 2011. And he was also recognized by the Frontiers Award from the Midwestern Society for Pediatric Research in 2012. 12. In 2017, he has received the Mary Ellen Avery Research Neonatal Award from the SPR and APS. Sir, please forgive me if I mentioned half the things that you if you have missed, if I'm not mentioned half the things that you I know you are really remembered for. Friends, I can go on and on, but let me not stand between you and the great legend himself. Let's straight away hear from the great legend. Hearty welcome, Professor Alan Jobe. Over to you, sir.
Thank you very much. Wherever you are, it's 10 in the morning here in Cincinnati. So can you bring up my slides?
Yes, sir. Are you able to see the slides, sir?
Yes. You want to go full screen?
Yeah, I will.
Okay.
Yes.
So I'm not just going to give you an update. I'm talking to neonatologists today, not obstetricians. And as you know, antenatal steroids are really an obstetric intervention. So there are some things about antenatal steroids that neonatologists should know about. So that's what I'm going to focus on today. Next slide, please. Next slide, please. Okay. The goals for this presentation are to appreciate that preterm infants have IQ deficits and acknowledge that we don't understand the causes. There are differences in drugs and effects of antenatal steroids on newborns. The developmental origins of health and disease concepts are issues that may be unavoidable because of bad effects on these tiny babies that we can't fix with our current therapies. I'm going to give some suggestions about dosing for antenatal steroids. This is actually more research. It's not something you should tell your obstetricians to do until we have some clinical verification. Next slide. Okay, this is just a concept slide I put together. If you look at the distribution of IQs for a normal term potential, you have a bell-shaped curve that looks like the black one for normal term infants with a mean value of 100. If you look at very preterm infants, the curve has three areas that are cause for concern. One is that the peak is shifted downscale by about 15 IQ points for the whole population. There's also a big shoulder on this curve where you have a bunch of kids who do have damage, and then there's a hump at the bottom of the curve for kids who are severely damaged. And so what we would like to do, of course, is to have that very preterm curve superimposed on the normal term potential, but we presently aren't there yet. Next slide. This is a meta-regression where each circle represents a different study. The size of the circle indicates the number of patients in the study. This is a massive study of all of these different IQ assessments on extremely low birth weight or very low birth weight infants versus term controls, so that there's a negative slope to this line based on the year that the study was published. So the problem is that this curve is not approaching a flat curve over a period of 20 years. So we could this be actually the result of antenatal steroids? Next slide. Next slide. Okay, so this is the same analysis looking at the outcome of bronchopulmonary dysplasia. And this curve is much steeper, so that the intercept is about a half a standard deviation down for IQ if you have bronchopulmonary dysplasia. So this is just an indication that bronchopulmonary dysplasia is contributing to our bad neurodevelopmental outcomes across studies. And this really is a function of the percent of bronchopulmonary dysplasia in your population. Next slide. These are data from insurance billing in the province of Ontario, Canada, where if you look at the rate of audiometry testing and suspected neurocognitive disorders based on age, it turns out that these are infants exposed to antenatal steroids but delivered at term. So it appears to be there's a concern about in the population about hearing, and there's also increased suspected neurocognitive disorders. So again, to make the point, these are infants treated preterm who deliver at term. Next slide. These are similar data from Finland, looking at preterm delivery after antenatal exposure or term delivery after antenatal exposure, looking at birth weight and head circumference. And what you see is there's a deficit in birth weight after antenatal steroids that's significant for preterms, near terms, and term. And the more concerning slide is to your right, for head circumference, where if you received antenatal steroids and deliver at term, you have a smaller head if you deliver at term or if you deliver near term. There's no difference in the babies who deliver preterm. That's presumably because there's a protective effect of steroids in that population. Next slide. These are the same kinds of data from Finland for the whole Finnish birth cohort, 670,000 births from 2006 to 2017. And there are 3 bar graphs. Back one slide, please. So for the entire cohort of term deliveries, the outcome, the neurodevelopmental behavioral assessment that these infants favor no steroids. If you deliver at term after exposed to steroids, your outcomes are worse. Again, the preterm infants seem to be protected from the bad back, please. One more. You're going the wrong direction.
That.
There we are. Next, okay. There we go. The preterm infants seem to be protected, probably because steroids do benefit these infants, both in terms of mortality and neurodevelopment. So I think this is the substrate on which we have to worry about antenatal steroids. The population that we have to be worried about that we don't think about is the kids that get treated with antenatal steroids but deliver at term. That's almost half of the treated babies that get antenatal steroids actually don't deliver preterm because they have decreased birth weight and they have smaller head circumferences, which means there's a biological substrate for the bad outcome. Let's go to the next slide. Let's go to the next slide. So this is a sketch that I made a few years ago about the hypothetical trajectory of alveolar number for preterms with severe BPD and normal lungs. And it turns out that if you don't have severe BPD, there's some data to say that you don't really have an alveolar deficit with mild BPD in alveolar number. So that the question mark there is that for the average very preterm infant, that curve is probably fairly close to the normal lung at term. The problem is that we have good data that the trajectory of those lungs is more like that dashed line there, that these lungs develop a abnormal FEV1, which implies that they will get COPD at an earlier age. Next slide. Next slide. So this is the meta-analysis that you all look at when you're thinking about antenatal steroids. These agents, when used appropriately for infants who deliver preterm, decrease death, decrease RDH, decrease IVH, very good because the number of infants assessed is much lower. Similar for NEC, and there's no effect on BPD. Next slide, please. So this is a new meta-analysis that came out in 2020, but I think there's an important message here that antenatal steroids are not as effective as most people believe. They're not a solution to preterm mortality in low and middle income countries because the decrease in death was from 11.9% to 9.8%, a relative decrease of 22%. For RDS, it decreased from 14.9% to 10.5%. This is a decrease of 29%. For IVH, it went from 3.3% to 1.4%, a decrease of 66%, a really big effect. The problem is those data are compromised by inadequate numbers. Let's go to the next slide. So the bottom line is, if you go and consent a woman to give her antenatal steroids, you can't say that this is a panacea that's going to solve her problem if her baby delivers preterm. Many of these babies still have RDS. This is a similar thing to the sketch I talked about earlier. That is that normal infants have lung function tracks in terms of how their lungs grow and develop to adulthood. These are for normal newborns. So what we know, I think now from a number of other studies, is our very preterm infants actually have a track which is quite abnormal. This is a slide, back one, that one, there we go. Back one, okay, that's it. There we are. This is a slide from Barbara Schmidt, which I think makes the important point that it's really important to avoid injury. So if the probability of a poor outcome at 18 months is about 20% at 18 months for these extremely preterm infants. If you have two morbidities, prematurity and BPD, that increases to almost 40%. If you have IVH, that goes up to 70%. If you have prematurity, BPD, brain injury, and a severe ROP, your chances of a bad outcome exceed 90%. So I think that's an important message that if we can avoid injury, we can improve our neurodevelopmental outcomes. Next slide. How do we make better babies? We avoid injury. It turns out that there are these developmental origins and health and disease effects that affect the heart, the kidneys, the lung, and blood pressure in these tiny babies. We don't know how to avoid those. If we can avoid prematurity and give antenatal steroids only to pregnancies that will benefit, that's the right thing to do. Again, it's not effective to give women who have an infant not at risk of RDS because of spontaneous maturation antenatal steroids. It's also not effective to give it to that woman if she actually doesn't deliver preterm, which we hope she doesn't under normal circumstances, because that increases the risk of poor neurodevelopmental outcome. And I'm going to talk to you about doses of steroids and suggest that we're using the wrong drug at the wrong dose, and we've been doing that for 40 years. Next slide. So the summary of outcomes, prematurity plus or minus antenatal steroids may cause early aging in the preterm. I haven't really talked about that. These DOHAD concepts of a metabolic syndrome caused by very preterm birth are maybe a substantial risk for the preterm. We have no clue of how to avoid these other than to prevent prematurity. And we don't know how to do that because we don't understand the pathways that are driving preterm delivery. We need to minimize antenatal steroid exposures to only pregnancies that will benefit. Next slide. We can't figure that out very well. The big overview of preconceptional, fetal, and early childhood outcomes that influence lung growth and development. This is a lung growth slide. I could have heart out there rather than, or kidneys out there. There are all these preconceptual factors: fetal factors and early newborn factors that drive these bad outcomes. Next slide. The other thing about steroids, which I think we don't talk about, and I won't talk about very much, is that we give almost all our preterm infants fetal exposure. Then with very preterm infants, we support many of our babies with hydrocortisone. And then with postnatal injury, we give steroids for BPD. And then as these kids are repairing and remodeling, they often are put on low-dose steroids. The point is each exposure can increase or decrease lung function, and each exposure is time dependent. Let's go to the next slide, just to remind yourself. So when we talk about antenatal steroids, it's complicated because different doses and different drugs are used all over the world. In the US, most of Europe, Australia, New Zealand, betamethasone is used as a combination drug. Betamethasone, 12 milligrams of beta phosphate and 12 milligrams of beta acetate, which forms a depot form, and I'll talk about that and show you some results with that. So we're actually giving two drugs. It turns out that betamethasone, this is called Celestone. It's actually not available in India. Then we give postnatal either Dex or hydrocortisone. The WHO antenatal steroid treatment is 6 milligrams or 12 milligrams of dexamethasone as 4 doses. It turns out in the UK, they use betamethasone phosphate alone, 12 milligrams, 2 doses, and no one else seems to use that. It's interesting that that's never been trialed. Next slide. So there's some characteristics of the adrenal function in the premature that we have to think about. The fetal corticosteroid levels are extremely low in these babies because of immature adrenal function. Cortisol synthesis is only significant after 30 weeks. Preterms are generally adrenal deficient at birth. They do better if we treat them with low-dose hydrocortisone. So what we have is we have an organism with a very immature brain adrenal axis that needs to mature in the first weeks after birth. Next slide. So we have a really complex pharmacology here. We treat the mother to treat the fetus. The variables nobody ever thinks about are dose and route of treatment, placental transfer, clearance in the pregnant woman, clearance of these drugs in the fetus. We have some data in sheep, and there's some data in humans as well, which I'll show you, that this clearance is very slow for betamethasone. We also don't know what dose is necessary for an effective pharmacodynamic effect on the RDS ideation death. Next slide. So these are PD outcomes from a meta-analysis done by the WHO. It turns out that for neonatal death, you have a benefit for anywhere up to 7 days. For respiratory distress, the major effects are between 48 hours and 7 days. For intraventricular hemorrhage, it appears that the interval is really tight. It's after 24 hours and before 48 hours that you have a benefit. That's in terms of the time to delivery after treatment. Next slide. So these are really interesting. I'll spend a moment on this. These are betamethasone cord blood levels in babies after preterm delivery. These mothers were treated with the standard Celestone dose of 2 doses of 12 milligrams containing 6 milligrams of beta phosphate and 6 milligrams of beta acetate. And it turns out that you can measure this in the cord blood 6.5 days after the baby's been treated. And you can get some very high levels there with the early treatment. I don't know if you can see this, but these guys are really high. And so that's a concern that the fetus is seeing those high blood levels. Next slide, please. These are maternal betamethasone levels. It turns out that this drug is still present in the maternal circulation 6.5 days after the last treatment. So our babies are seeing antenatal steroids for a very long period of time after they're delivery, even if it's 6.5 days after treatment. Next slide. These are newer data from France with cord blood levels and maternal levels. The red circles are 3 to 4 days after the second treatment with this drug, and the drug is still measurable in the cord blood. It's still measurable in the maternal blood. So I think we have to realize that our babies who are getting antenatal steroids actually have drugs in their circulation for even after a number of days. Let's go to the next slide. Okay, so these are studies that were done in Bangalore with the support of the Gates Foundation. We went there to do PK studies. These are studies that should have been done 40 years ago. These are in non-pregnant reproductive age women. There were 48 of them. And we randomized them to the drugs that are used for antenatal steroids, dexamethasone phosphate, betamethasone phosphate, the drug that we use in the US, Celestone, the two-component drug. The problem, that was a pain in the ass to get into India because it's not available in India. It actually took almost an act of God to get it in there so we could do these studies. And so we're dosing it IM or orally. Now, why do we give this drug IM to these women? Well, it turns out that most of our use of betamethasone or dexamethasone in patients are given orally. The pills are stable and they're very cheap. So those overlapping curves there are for dexamethasone or betamethasone, IM or oral. And you can see there's really no difference in the clearance from these non-pregnant reproductive age women. On the other hand, there's this curve that has two slopes for the Celestone. The initial slope is the beta phosphate component of the curve, which overlaps with the blue symbols. And then there's a point out at it's about 8 days, 10 days. It turns out it's still measurable in these women. So when we give them the clinical drug that's used over most of the world, we still have blood levels in these women. And it's actually at a level that can give effects in animal models for lung maturation. Let's go to the next slide. So I want to show you this because I think this is something that's you should worry about. These are these same studies looking, so the first, up to the first 24 hours is the normal physiologic diurnal rhythm of cortisol in these women. It's back up to about 70 the next morning, and then we dose them with these 5 different drugs. And what happens is their cortisol is completely suppressed. It just goes to 0. And you can see that with the betamethasone IM or PO, these women remain suppressed for 60 hours. That's 2.5 days. If you give them the Celestone, they're suppressed for 96 hours. Let's go to the next slide. Next slide. Okay. I've added a second curve here on the left, and this is plasma glucose. This drug also messes with your glucose. These are non-pregnant women. So that, again, with dexamethasone, IM or PO, these are actually the IM data. It turns out that maternal glucose goes up and it stays up for about a day and a half. That cortisol curves are shown there as well. The end result of this is that we're messing with these women's cortisol and plasma glucose. And of course, high maternal plasma glucose put up the fetus's glucose and increase the fetal insulin, which means after delivery, the infant is likely to get hypoglycemia. Next slide. So this measurement is the rebound time, the time to return to the baseline value. And it turns out that for cortisol, that's a long time. So our women who are in the hospital after getting steroid treatment, awaiting their preterm delivery, are adrenal insufficient because they have adrenal suppression. Their neutrophils are elevated, and those stay elevated for a while. Their basophils change, their T helper cells change. These are lymphocytes now. Their T suppressor cells also change. The shortest rebound times are for dexamethasone because it has a more rapid clearance. The longest is for betamethasone, or the phosphate acetate combination drug. Next slide. So these are cord blood concentrations from a recent publication in Journal of Pediatrics from the Epicure study. And what it shows is that these units are nanomoles per liter, and that there are babies that have, even at very early gestational ages, out here, that have incredibly high cortisol levels. And this is boys and this is girls. So some of our babies actually at the time they're born have very high cortisol levels. That means that their adrenal function has been induced because the normal fetus has very low cortisol levels. So, and these high cortisol levels in these populations of babies correlated with BPD and NEC. So, of course, the total cortisol level is actually higher because these babies probably have some steroid levels left over from their maternal treatments. Next slide. These are cord blood beta plus cortisol levels as a calculation that are data recently out of Finland. And so you can see these are cord blood levels. These levels are very high cortisol equivalents. And this is the mean PO2. So it seemed that the high cortisols did correlate with a better oxygenation in these babies. So these are just all indications that our babies are exposed to more steroids than we understand, and our women are adrenal suppressed. Next slide. So these are experimental studies in my favorite animal model, sheep. If you can see on my tie, those are sheep. So these are this is the clinical drug used in the US and Europe. This is one dose of the clinical drug in fetal sheep 48 hours after the initial treatment. 2 doses or 1 dose. This is measuring dynamic compliance in these preterm animals on mechanical ventilation. And these values are for half of the betamethasone acetate dose, 0.125 milligrams per kilo. And these are the pressure volume curves for the clinical dose and that half dose, this group here. So there's no difference. So the point is you don't need all this high dose of drug to get a clinical effect in a sheep. Next slide. Next slide. So in the rhesus and macaque, as a summary, 1 dose of 0.125 milligrams per kilogram of beta acetate is comparable to 2 clinical doses of 0.25 milligrams per kilogram. So the pregnant woman is getting about 0.5 milligrams per kilogram of beta phosphate plus beta acetate. Maternal and fetal blood levels for lung response are very low and possibly lower in pregnancy. A dose of 0.06 milligrams per kilogram showed less lung maturation in the monkey. Therefore, lung maturation does not require a high peak beta level in the fetus or dex level. The fetal blood levels are low and maintained for greater than 24 hours, cause lung maturation. Next slide. These are plasma levels in rhesus macaques, the favorite monkeys you have on all your Indian temples, at 0.125 milligrams per kilogram to non-pregnant monkeys, to pregnant monkeys, and to the fetus. This is done by cortocentesis of the fetus, measuring actually fetal cord blood levels in utero with a pregnancy that continues. And it turns out that we get lung maturation in incredibly low concentration, about 1 nanogram per milliliter in the monkey. These are the maternal levels. They're only about 2 nanograms per milliliter. Next slide. These are experimental studies now where we treated these monkeys with these various steroids and waited 5 days and then delivered them. This is for the beta acetate 0.125 milligrams per kilogram. And this is for the clinical drug. This is for a lower dose. So again, this low dose is equivalent to the clinical drug in the monkey. And this is the amount of surfactant. If anything, this is better. It's not statistically better, but it's better than control. And the lower dose didn't have a statistical event. This is now published. Next slide. So these are fetal levels after maternal treatment, which cause lung maturation for the sheep and for the monkey. In the sheep, it looks like it's also a low level. We have data that it's about 1 nanogram also in the sheep. And in the rhesus monkey, it's about 1 nanogram per milliliter. So these are very low levels. Next slide. So beta phosphate and dex phosphate are equivalent except for their PK values. And I think you're using dex phosphate in India. The blood levels are proportionate to dose in the mother and the fetus. A minimum dose, assuming anti-inflammatory effects, have some similar dose for fetal lung maturation. It's low. It's about, if you're using beta phosphate alone, it's probably 8 doses of 0.15 milligrams per kilogram. Dose next slide. There's 2 pathways to lung maturation that we've been working on. One is antenatal steroids. The other is exposure to chorioamnionitis. It turns out the chorioamnionitis is more potent than the steroid exposure. So it turns out that if you look at individual effects of LPS or beta, they're actually overlapping for both saturated phosphatidylcholine and the pressure volume curve. But if you combine the two, if you give beta acetate to a monkey that's received antenatal steroids. You want to answer that?
Yeah.
My cell phone just went off. My wife's going to answer it. Okay. Hit the microphone. So to gather my thoughts here again, the betamethasone acetate and the betamethasone LPS inflammatory exposure intraamniotic causes lung maturation, which is better than either stimulus alone. Next slide. So there's an issue that nobody really thinks about. It turns out that even from the randomized controlled trials and the meta-analysis, only about 40% of fetuses exposed to antenatal steroids have a lung maturation response. LPS inflammation causes consistent maturation in animal models, a larger effect than the antenatal steroids. We need to better target antenatal steroids to get those, to see those who benefit. Consider that repeated doses just have more adverse effects, and consider a lower dose. Next slide. So why do only 40% of the fetuses respond to, I talked about the complexity of the fetal drug exposure. Well, it could be that there's different drug exposures for different fetuses if they're growth restricted or not, for example. It could have to do with variability in maternal drug level, placental transfer, fetal blood level, and clearance, or a different drug. There could be a biological difference in maturation of the target cell or steroid receptors. So we tested this in a sheep model. We gave 10 maternal fetal pairs, catheterized animals, a saline placebo, and 20 maternal fetal pairs, the clinical drug, betamethasone acetate plus phosphate. And we measured maternal and fetal blood levels. And we evaluated pharmacodynamics of lung maturation versus fetal exposure. Next slide, a direct test of the issue. So we've grouped our babies based on the B frame. These are ventilated preterm lambs, PCO2 effects. These are the control PCO2s. They're way over 120. The responders have PCO2s between 60 and 70. I'll talk for 45 minutes. I'll try to get through this quickly. You can see that the responders and the non-responders look like the controls here and here. But it turns out that responders have lower PCO2s, higher PO2s, lower heart rates, and lower mean blood pressure. Next slide. If you measure maternal betamethasone levels in the responders and the non-responders, the maternal curves actually perfectly overlap. So do the fetal curves. So it's not the drug exposure that's changing this, which means I've already talked to you about the fact that we need lower doses. So higher doses of steroids isn't going to get more of these women to respond. It's something basically to do with the pharmacology of lung maturation at the cellular level, something we don't understand. Next slide. It turns out that the drug exposure of the fetus is really low because the total drug is mostly protein bound in the maternal plasma. This is the amount of free betamethasone that these fetuses are responding to. It's incredibly low levels. Next slide. So many women exposed to antenatal steroids, the fetus is already mature, even at an early gestational age. Most fetuses at less than 34 weeks will not benefit because most of your 30-weekers don't have RDS or to do the 34-weekers. Are there opportunities to identify and treat only pregnancies that will benefit? And the answer to that is no, we don't know how to do that yet. So at this point, I think I'll just stop and not show my last couple of slides. Thank you very much. Let's go to the discussion.
Thank you so much, Professor Jobe. Sir, it was a very interesting and novel concept that we're hearing now. Now we'll have the question answer session. May invite the moderators for the question answer session. Dr. Rahul Verma from Mumbai and Dr. Rema Chandramohan from Chennai. Over to you.
Good evening.
Yes, good evening. And first of all, thank Dr. Manoj for the opportunity and Professor Alan Jobe. It's an honor to be here today. We very much enjoyed listening to you and a lot of questions I think you have answered during your talk. Dr. Rahul, would you like to go ahead with the questions?
Sure. So the first query, which has come from Dr. Kumudini, the query is, would you recommend, Professor Jobe, a second course of antenatal steroids after a week of having completed the first course if the baby has still not delivered?
Well, it's really complicated. I showed you data that a week after treating these women if you're using Celestone, which I know you're not in India, it turns out that if you're using dexamethasone, the fetus won't have any residual steroid because it's cleared quite rapidly from the mother. So I don't know the right answer. The problem is many of these women who don't deliver within a week of the first dose actually aren't going to deliver full term. And so what you're going to do is end up giving more and more drug as they get older and older until they get out to 34 weeks. And I think repetitive treatment is just likely to cause more developmental abnormalities. So I'd be inclined not to do that. I mean, I think in the circumstance where you get a woman with ruptured membranes at 25 weeks, and you give her steroids and she hasn't delivered by 7 days, and she's going to deliver at, soon, or you're going to deliver her soon, probably giving a second course has some merit.
Right. Dr. Rema, you want to take the second question, or should I continue?
Yeah, the second question is from Dr. Prashant, and he says, could you please discuss so these findings make us think? Yeah, so he's asking about the role of antenatal steroids in those babies who are late preterm or early term.
Okay, I mean, the problem with the late steroid treatment is that, again, the outcomes in terms of what I talked about, in terms of the neurodevelopmental effects, still apply. So these babies still have a smaller head circumference and a lower weight. So that's not very desirable. And if you're in Finland, then your behavioral assessment is abnormal at 10 years of age. So the problem with that is the benefit is really for neonatal transition. And there was no effect on RDS in the big randomized trial from the US. And there was increased hypoglycemia. So if you're in a really low resource environment where you're not prepared to deal with hypoglycemia, then I would suggest not treating these late preterms with antenatal steroids. And that also applies to the behavior in some places of the world of treating all your elective C-sections with antenatal steroids. There's no question that you can improve their neonatal transition if you do that, but it's probably just an unnecessary risk.
So you do not recommend antenatal steroids in those patients?
I know the American Academy of OBGYN does, but the more I look at the developmental data, the more concerned I am. And I mean, I think that that's a risk that you don't need to take, because most of these kids are going to do fine anyway.
Yes, yes.
So I mean, I think everything is environment specific. So if you're in a place where, if you have a 36-weeker, if you have 36 weekers dying of RDS, then maybe you'd want to use this. But in Cincinnati, those babies do fine. So, any rate, I think everything depends on your environment. If you're prepared to take care of hypoglycemia and you're prepared to take care of mild respiratory problems, then you probably shouldn't be using steroids in these late preterm pregnancies. The other problem is, of course, you're adrenal suppressing the mother for a couple of days, right at the time that she's trying to transition to breastfeeding. And there's actually some data that antenatal steroids mess with the ability to breastfeed.
Okay.
So that's a complicating issue as well.
Right. So Dr. Prashant continues to ask, would small for gestational age and babies and fetuses with high risk for infection, intrauterine or extrauterine, I'm not sure, especially in our country, would that worsen the concept of giving antenatal corticosteroids?
Well, I think we don't have any randomized data looking at SGA babies or growth restricted babies, but they already have a growth problem. So if you give steroids, they're going to have more of a growth problem. So that doesn't necessarily help you any. In terms of infection, there's been good studies to show that many of these women that present with preterm labor actually have low-grade infection or low-grade inflammation. And if you don't have florid infection, it's probably a good idea to, there's a meta-analysis from Jane Hearty a number of years ago that those babies actually profit from antenatal steroids. But if you're frankly infected, the only thing you can practically do is deliver the baby and treat the baby. So I think you shouldn't be using steroids. The problem with steroids is, for many of their effects, they're not going to work for a day or two. So if you have a lady you think's infected, it's probably more important to get her delivered than to treat her with steroids and wait a couple days for a benefit of the steroids.
Okay. So there's somebody who's asked, Dr. Jagjit has asked, could ANS response by the fetus be due to pharmacokinetics differences secondary to ethnicity and etiology of preterm birth?
It certainly could. That's not been studied at all. Let me make a comment about this low dose stuff. We think that the low dose makes sense, and we have data in sheep and monkeys that it works. So the WHO and the Gates Foundation is designing a trial right now that will be conducted in India and Africa sometime once COVID blows over, to test a low dose strategy using beta-methazone phosphate. So that will probably take 3 or 4 years. It's a study of 14,000 pregnancies. So it's going to take a long time to do. And so while I think it only makes sense to use lower doses, we don't have any clinical proof that it works at lower doses. So I can't recommend to you that you should be using lower doses of dexamethasone in your mothers.
Right. So you did make a passing comment that we need to be clear, or we need to try to find out which pregnancies would benefit from antenatal corticosteroids. So Dr. Daljit was wondering whether clinically, is there any way as of today that we can decide which pregnancies would benefit from a course of antenatal corticosteroids in the setting of prematurity?
Yeah, well, there's no present way, there's no blood test or there's no ultrasound findings that can clue you that that's going to happen. The molecular people at Stanford are doing studies to try to figure that out. And you can actually profile mRNA and amniotic fluid and profile lung maturation. So theoretically, you could use amniotic fluid, measure mRNA levels for a number of different RNAs, and then with sequencing, figure out which pregnancy is likely to deliver preterm. But by the time you do that, she will have already delivered before you could have given her. So we don't really have a way to do that. That's it seems to me, is everybody wants us to do personalized medicine. So this is a perfect situation to do personalized medicine. If you can figure out who to treat, then we can avoid all these term deliveries of women who are treated with antenatal steroids. There's really good data now that if you were treated with antenatal steroids as a preterm, that your neurodevelopment isn't going to be as good if you deliver at term with normal APGAR scores after getting antenatal steroids. So that's a real problem, it seems to me. And if you figure out how many patients are actually being treated and deliver at term, it's not trivial, because about half of the patients that you treated for prematurity will deliver at term. And then there's a bunch of other ones that get treated for a variety of reasons. So, I think it's a problem. I think you have to realize that if you're doing studies on developmental origins of health and disease, about metabolism, lung development, heart development, and all these different things that people are now studying, that metabolic syndrome, that that if you want to do that in an animal model, what do you use as an agonist? You use steroids. So that's the stimulus that people study to cause these developmental origin problems. This is obviously a problem in India because the developmental origin problems include diabetes, obesity, hypertension, and all those other things.
There is Dr. Salkat, who wants to know if the dose and course of antenatal steroids is any different in a multiple pregnancy.
The answer to that is that it hasn't been studied formally, but pulling out twins from a lot of large cohorts would suggest that maybe it's not quite as effective, but it has some efficacy and should be used for very preterm twins. which are actually a high number of these very preterm pregnancies. So the answer is yes, it's not a definitive answer. And you don't change the dose because the reservoir for the drug is the mother, and the fetuses, if they're preterm, aren't very big. So it's not like you have to give a double dose because there's two fetuses. You use the same dose, which is the wrong dose, by the way, but that's just the way it is.
Thank you for that. Professor Divakar asks that one of the slides which you had presented indicated actually an increase in the incidence of necrotizing enterocolitis with higher steroid levels. So would that be contrary to the accepted presumption that antenatal corticosteroids have an additional benefit, or actually they increase the risk of NEC? That was
the data again from the meta-analyses would indicate that actually antenatal steroids may decrease NEC. The problem is those data from the Epicure study that I showed show that many of these babies have very high endogenous steroid levels at the time of delivery, which, and that correlated with NEC and IVH. So that means that whatever caused the stress and the maturation of the adrenal axis in that fetus then is driving those bad outcomes. It's a little bit of a complicated concept.
So with chorioamnionitis, can we use corticosteroids? Dr. Ahumada has asked.
Yes, I think you can, again, as long as the woman's not, really symptomatic, because women who are symptomatic with infection will almost always deliver fairly rapidly. So if you have one of these women, you don't know. The way this has been worked out is to do amniocentesis and look for IL-6 in the amniotic fluid to find out who's been exposed to inflammation. A lot of these, according to Roberto Romero, are sterile inflammation exposures of unknown cause. Those babies probably respond to steroids. And I showed you data that actually you get an additive response with steroids plus a low-grade inflammation exposure in the fetus. So I would say if you have a woman who shows up with unknown cause of preterm labor and you think she might have infection, you might be right. The only way you can find out is to do an amniocentesis, which most people aren't doing now. And if you don't do that, then, and she's not fully dilated and not delivering, then it's probably reasonable to use steroids on the assumption that she may have some low grade, she may have something like ureaplasma, which doesn't cause florid symptoms in the mother.
Right, going on, plodding along. So interesting question by Dr. Gowda. Would you consider antenatal corticosteroids in a term baby who is going to undergo a scheduled cesarean section?
Well, I think you can be confident that a scheduled C-section will have more abnormality in neonatal transition than a labored C-section. And everybody wants to do scheduled C-sections because then you don't get in the problem of labor when you're trying to do the C-section. But I understand that. But the problem is that that's being done frequently in Brazil, Chile, and Argentina, actually. So it will make the neonatal transition better. It won't prevent RDS. And there's some data that the outcomes, neurodevelopmental outcomes of those babies is actually okay. But if you don't do an elective C-section until after 38 weeks, you shouldn't need to use steroids.
Dr. Ramachandra Rao has asked about rescue dose of steroids.
Well, there's not good data on that. The trial of that was out of Finland many years ago, and it showed no benefit. The problem with rescue steroids is that it's incredibly hard to time this. So you have a woman who presented at whatever, 28 weeks, and you gave her steroids, and then she doesn't deliver, and she comes back, she goes home, she comes back at 30 weeks. Then what do you do? And if delivery is imminent, then trying to get her treated with steroids for 48 hours before she delivers may not work, because she may deliver before then anyway. And so it's very hard to get this time. So by the time you get to the woman who's been treated and then comes back at a gestational age where it's okay to treat with steroids, you're talking about a very small population of women.
Right. Another query from Dr. Goyal. She would like to know whether an accelerated regime, that means instead of giving betamethasone 24 hourly, would it work better if we were to give it 12 hourly? Because I suspect this this regime is being practiced in quite a few places in India.
Well, it turns out that that's, of course, never been trialed. And probably you're using dexamethasone. So I'm trying to think about the pharmacokinetics of that.
And some of us are using betamethasone, though it's not in a combination. It's just betamethasone phosphate.
Yes, okay. So if you're using betamethasone phosphate, you probably don't need to do that, because the clearance kinetics are so much slower than they are with dexamethasone. If you're using dexamethasone, it's pretty much cleared by 6 or 8 hours. So it might make sense to do an accelerated course. Nobody's ever tested that. I can't make a recommendation. I just think if you think about the kinetics of these drugs, everything depends on drug levels. But what we know is if you give these doses of 6 or 12 milligrams of betamethasone phosphate or dexamethasone phosphate, you get incredibly high levels in the mother. It just as a comparison, the dose of dexamethasone used to salvage COVID patients who are dying on the ventilator is 20 milligrams. We're giving more than that to the women. So we're treating them as if they've got lethal COVID in terms of the dose of steroids. And what we do know from the monkeys and the sheep is that those very high levels that get into the fetus don't have no benefit. It's just a risk benefit. So I would be inclined not to give repetitive doses of phosphate conjugated drugs. I think that's the safe recommendation. Don't try to accelerate it. In particular, if you're using celestone, then you shouldn't accelerate it, because the betamethasone acetate will be around. Now, so I talked a lot about betamethasone acetate. It turns out that that's not a drug that's available anywhere in the world for IM use as a single component drug. So there's no way you could just use that. It has you can think about some advantages of using that, but it's not available. So that's not in the discussion. So if you're going to do retreatment, you're going to be using beta phosphate or dex phosphate. The dex phosphate has a much more rapid clearance rate. And so retreating makes some sense, while the beta phosphate has a much slower clearance.
Dr. Indu is asking whether we should start recommending lower doses of antenatal steroids.
I think we can't until we have a clinical study proving that it's efficacious. And that study, unfortunately, is a very big pain in the ass to do, because it's unethical not to give women steroids. So you have to do a comparative study using all treated women against whatever your normal treatment is, and then use a lower dose. So it's difficult to do the study. It blows the numbers way up in terms of how big the study has to be.
Right. The next question comes from Dr. Flores. The question being asked is a bit tricky. Let me try to understand that. So we are aware that extremely preterm babies have adrenal insufficiency. How may we help this without administering corticosteroids? I presume it's talking about antenatal corticosteroids and its impact on an inherent adrenal insufficiency seen in preterm babies.
I don't know of data if corticosteroid treatment of the mother induces maturation of the hypothalamic adrenal axis in the fetus. I don't think that's ever been studied.
There is another question from Ramachandra Rao. He wants to know, instead of giving a standard dose of antenatal steroids, can we give the dose based on the maternal BMI?
It turns out that my study I did in Bangalore, all the women had the same BMI. All of them had a BMI of 24. You wish your patients had a BMI of 24. At any rate, the bottom line is that there's been studies looking at BMI versus clinical response, and it doesn't seem to make a difference. That's probably because we're so high on the dose response curve that that giving more drug based on BMI doesn't really make any sense because we're overtreating them already. The pharmacology of it sort of doesn't make any sense.
Right.
I mean, if we get to be using low dose, then it might be that treating them based on BMI when we're trying to use the minimum dose would make sense.
Yes.
Fair enough. Dr. Bisht wished to know that if dexamethasone in all probability would seem better if the delivery is imminent within the next 48 hours. So would this rapid clearance be a disadvantage if this delivery was then prolonged to 4 to 5 days after the administration of dexamethasone?
I haven't really thought through that very much. The issue is, at least in animal models, at least in sheep, you get lung maturation effects within 24 hours. And they're the same at 48 hours. So you get very rapid effects on the fetal blood pressure and the fetal heart rate within 24 hours. So if you're using the phosphorylated drugs and you were treating a preeclamptic and you wanted to wait 48 hours to deliver, I would argue that the best drug to give is beta-methazone phosphate.
Dr. Rajiv has asked whether does this data raise questions on the utility of ANS?
Well, no. I mean, we have the randomized controlled trials clearly prove that antenatal steroids are effective. It's just that we're using the wrong dose. And we're using such a large dose that there's no way that a bigger dose is going to work better. So, no, I mean, I think we have data that these drugs work. The problem is getting them dosed right. So the history of this basically is interesting. It turns out that Montliggins treated a woman with this dose in his trial in 1971. And no one ever did pharmacology on this. So this drug is not approved by the FDA or anybody else. So the pharmacology has never been done. So that's why we did that study in Bangalore, to actually do some formal pharmacology on these drugs. These drugs have been available since the 1940s, so it's not like these are new drugs. It's just that no sophisticated studies have been done. So no, I don't think there's any question that antenatal steroids have benefit. So we should continue to use them at the doses being recommended because we don't have any proof to do it any other way. So first we have to get the trials to show that. And then I think we'll find that we can use much lower doses. And we can actually use it orally because the pharmacokinetics are the same. And for you folks in low resource environments, that's a great environment, because a great solution. Because if you have a woman who's in an outlying clinic and there's nobody to give an IM dose to, you can just give her a pill, a 2 milligram dex pill, and then have her go to the center. But so that would be a real advantage. The dex, you don't need a shot, and you don't have a drug that you have to worry about sterility and needles and all the other bit. So anyway, I know the Indian ladies like to have shots because they think you're doing something for them. So
Yes.
anyway.
Right. Next question comes from Dr. Pandita. It's a bit of a twister. What is the difference between in utero exposure of the fetus to corticosteroids and postnatal steroids exposure to the same steroids and the same dose? I am not sure how this works out, but I suspect the maternal dose is different, but probably the levels is what I presume Dr. Pandita is talking about. And can the same dose of postnatal steroids replace antenatal corticosteroids, as it is easy to pick up at-risk newborns postnatally? All yours.
So
The same dose can be given postnatal.
there's been very little data on postnatal steroid levels. I showed you that stuff where some of these babies had really high levels, they had cord levels,
Yeah.
based on gestational age in boys and girls. So that suggests to me again that what we don't know is we don't know the adrenal status of our baby at the time of delivery, which is an interesting question, because if you have a baby that has high cortisol levels endogenously, then it makes no sense to give that baby steroids and just suppress endogenous function, which is what you would do unless you're going to use high cortisol. So there'll be a session on that about this issue at Hot Topics. So you can tune into that, and maybe we'll have a better answer. That's about the best I can do right now.
Dr. Bhaskar Reddy wants to know if the antenatal steroids given to preterm mothers in the current scenario of COVID, will that affect the outcome of babies if the mother is COVID positive?
I have no clue. There's no data on that at all. I mean, I know there's been a discussion that if the woman shows up in preterm labor with COVID and ends up in the hospital, do you treat her with steroids? And I think people say that's probably okay because we're treating the severe cases with steroids. So I'd probably use dexamethasone because that's what they're using for the COVID cases.
So another interesting question from Dr. Alka. There are mothers who've been treated for chronic ITP, and long-term treatment with steroids have been going on in such mothers with no discernible effect on the fetus. So would long-term steroid not have the same effect? Or should I say linked? So yeah, I think it's long-term steroid not have the same effect.
Well, the issue is what steroid are they using? Because you've got to have a fluorinated steroid to cross the placenta. So if they're using prednisone or hydrocortisone to treat these people chronically, it's not going to cross the placenta. So it won't have much in the way of a fetal effect. If you're using dex or betamethasone, then I would argue that it's probably had a fetal effect. But you just may not be looking carefully enough to find it. You may have to look at a metabolic effect.
The next one is, would fetal fibronectin help?
I think we lost Professor Jobe. I could be wrong.
I can see,
sorry.
I can see
You just
myself.
moved. You just moved. Sorry, my apologies. You were on the right side and then you moved on the left side.
If the fetal fibronectin is positive, should we still go ahead and give steroid, or should we withhold because it is a threatened preterm labor?
I don't know the answer to that. I mean, I'm not aware that our obstetricians use fetal fibronectin for anything. So I just don't know the answer. I don't know the answer to that.
That's
I can't make.
say.
Yeah.
Okay.
Let me make a statement. I'm not an obstetrician, so all my recommendations have to be taken with a grain of salt. This is really an OB drug. They're making the decisions.
Yeah. Okay.
Right. So we carry on. Dr. Malhotra was wondering by a statement you made, I think, early on, which stated that babies of early gestation are mature. I'm sure there was a context to that.
Well, the thing is, we know that even if you're born at 25 weeks, some of those babies don't have RDS. They don't all have RDS. That's a problem because in the data sets, if you have been on any oxygen or anything, people say you have RDS. So my take on that is basically that a lot of these very preterm infants have induced lung maturation. That's probably because they either have an induced endogenous adrenal axis or they've been exposed to inflammation. So, you know, if you look at a population of 34 weekers, only about half of them have RDS at the time of delivery. So that's just, so again, those are pregnancies, if you were clever, you wouldn't give steroids to because there's no benefit if you could identify them. But we can't, we don't know, you know, we don't know who's gonna have RDS and who isn't. You could do an LS ratio on the amniotic fluid, but nobody's doing that anymore. The whole issue of antenatal lung testing is basically not performed anymore because the obstetricians basically take the position that it sort of doesn't matter. You're going to treat them all with steroids anyway. And when they deliver, and then they either have RDS or they don't. And then you give them surfactant and you take care of them. So it doesn't really make any difference if they have a mature LS ratio or not. Does that make sense?
Somewhat. Dr. Manjusha is asked if upregulation of genes.
Actually, it is a question from the YouTube. She has posted. The name of the person asked is down below, just below that. Actually.
Dr. Shenoy. Right.
Sunita, is it?
Yeah, but she is posting the questions live from the YouTube. That is why it's coming in her name.
Okay, Dr. Srikanth has asked this question. If upregulation of genes happens as a mechanism of the steroid, why do we need to go for a repeat course?
Why do we need to go for a complete course?
Repeat course.
Repeat course.
Yeah.
Actually, the repeat courses are quite ineffective. If you look at the meta-analysis of Carolyn Crowther, who's done many of these studies, it turns out that with repeat courses, there's no effect on death. There's no effect on RDS. It's just on neonatal transition that they seem to have effects. So a repeat course doesn't really get you very much other than the potential for more toxicity. I mean, I think the thing that I'm taken with is my concern for the neurodevelopmental, which I think is underplayed. I think a lot of these studies don't do elaborate neurodevelopmental assessment, so we don't really know the subtle effects. There are actually data in the literature to suggest that antenatal steroids are associated with psychiatric disease in later life. So any rate, I think we're using a really potent drug that we don't really understand the potential implications of. That's all. So don't use it if you don't have to.
Right. Dr. Sunita was wondering if the approved steroid, would it make a difference whether it was given orally or does it have to be injectable for bringing out the best of it?
Well, I think ultimately it has to be trialed. Nobody really knows. I mean, we have the pharmacokinetic data that there's no difference in maternal drug levels. We actually did oral dosing in sheep and in monkeys, and it works just fine in terms of lung maturation in those models with oral dosing. Trying to give oral steroids to a sheep isn't exactly fun. You have to put a tube down in them and then they barf on you. At any rate.
Yeah. Dr. Srinivas wants to know what's the minimum period required for any advantage of steroid before delivery, because we still see a lot of mothers getting the steroid and delivering immediately. So is there a minimum period which will confer any benefit?
Well, I mean, I can only go to animal models. There's no data. There's no clinical data. But in a sheep, you can have an improvement in lung function at 12 hours. And you have a change in the fetal blood pressure within 12 hours. So it can be quite rapid. So I think the answer to that is, if you don't, obstetricians can't predict much of anything very well. They certainly can't predict when women will actually deliver. So if you have a woman who's in preterm labor, the better part of valor is to give them steroids and then hope she can go for a couple of days.
Yeah.
Right. There's another query coming in from the best hospital in mother and child care. Would you advise to give dexamethasone now rather than betamethasone after looking at all these studies, the dosages, the impact, the onset of action?
Well, I guess if I had a choice, I would use betamethasone phosphate rather than dexamethasone phosphate. It's got a longer half-life, so it's less tricky to use. And that's what the English have been using. And there was a recent study comparing betamethasone phosphate with, I think it was with celestone, and they were equivalent. So I think it's safe to use betamethasone phosphate. If you have a choice of a phosphorylated drug to use, I'd use betamethasone phosphate. It turns out we can't do that in the US because there's no IM betamethasone phosphate available in the US. It's not like it's not an approved drug. Nobody makes it, that's all. Our favorite drug is Dex. That gets used for everything. BPD and everything else.
Dr. Manikumar is asking, our dexamethasone doesn't have sulfite, but ours contains paraben. How safe is it? Are we justified in preferring dexa over beta? Yeah, you've answered that part. How safe is paraben, which is there in our dexamethasone, he asks.
There was this business about sulfites and antenatal steroids a number of years ago. I don't think that makes any sense, because if you do a calculation on the volume of distribution of the mother versus what the fetus is seeing, the fetus isn't seeing any of that. For example, with the sulfites, it turns out that your hyperalk solution, your amino acid solutions, are preserved with sulfites. So when you're giving hyperalk, you're giving the baby much, much more sulfite than the baby will ever get from drugs given to the mother. So I think that there's in terms of the incipients that they put in these drugs, it becomes irrelevant when you're treating the 50-kilo woman and you're treating the uterus, which weighs a total of 1 kilo. The target of those bad components is not going to be the fetus, it's going to be the mother.
Apologies for interrupting in between. Can I ask Professor Jobe, because we are nearing 9 p.m. in India, do we go on and on, or do we stop, or whatever is whatever you want to do, sir? Because
Well, I'm about
talk
ready
has
for
evolved.
I,
I mean,
I'm about ready for lunch.
okay.
I think we've done enough questions. So you,
Maybe one or two questions and wind up. Is it okay, sir? Or shall I stop
yeah,
straight away?
yeah. Go ahead.
Okay. So Dr. Kadam is asking that given the benefits of antenatal corticosteroids, would it be worthwhile considering a uniform policy of giving steroids to all mothers at say around 26 to 28 weeks so that the babies, if they deliver earlier, would be benefited?
Well, I think that's a really bad idea because then you're giving the steroid exposure to everybody. And so most of those women will go to term. And I showed you the data that if you go to term after antenatal steroids, you actually have behavioral problems if you're born in Finland at 10 years of age. And you have smaller head and you have a lower birth weight. So I think that's a really bad idea to treat the whole population.
Yes, I think you've answered this already, but Dr. Akash is asking the difference between celestone versus using only beta-methazone phosphate in long term. He's asking about neonatal outcomes and side effects.
Well, no one is really, most of the papers you read on long-term outcomes don't even say which drug the woman had. They're coming from epidemiologic databases that don't have that information in it. So
Wait and see. Next.
I've lost the question.
Yeah, I think yeah, the next one, I think. Yeah, so we don't have data on that. So Dr. Rahul, the next one.
Sure. So Dr. Atre is asking, the concern regarding lower brain volumes or occipitofrontal circumference with the use of dexamethasone versus betamethasone, is it valid beyond a few studies? I mean, can we generalize about this observation now?
Well, the problem is no one's looked at dexamethasone versus betamethasone for those effects. So we don't know if it's the drug effect or if it's just the fact that they got. I think that the data from, if you're curious, look at the data from Finland that I put up on that slide, because that's on 670,000 patients, the whole delivery population of Finland over 12 years. So that is pretty compelling data.
So the next is, what should be the future studies about the antenatal steroids, addressing what all new aspects about the steroids?
Well, I think the things that need to be studied are low dose, oral versus IM, and you know, then, and that's about it. If we knew that, we would know better what to do.
Yes. Yeah. Dr. Rahul.
Yes. Dr. Barot is asking about what is the WHO action plan?
Well, the WHO action plan right now is to do, they did this study comparing there are 4 doses of, they compared 4 doses of dex phosphate, 6 milligrams versus placebo, and showed benefit. That was a study that was published in the New England Journal about 6 months ago. Then they're now designing this new low dose trial. So we'll have to see what happens with that. That'll take a long time to do. So that's what their agenda is now.
Shall we?
Yeah, because our questions are being repeated, I think we can call it a day or the night.
One last comment from both of you moderators before we wind up. Yeah. or I mean, if you want to ask anything, if you want to say anything.
Dr.
Then
Rama?
one after that, I would request Professor Jobe also to give a last message. In the talk, the final word in the talk, and then we'll have the photo. Thanks. Please go ahead.
Yeah, my only message is that antenatal steroids have revolutionized preterm care and the outcome. And this only thing is whether we are giving them higher doses, as Sir has been telling us. So if we can have a final word on a lower dose of steroid, I think that would be the best that we can do for our preterms.
Yes, Dr. Rahul.
No, I mean, my take on this is, unless proved otherwise, as of now, if the reduction in mortality and complications is anything more than 10%, I think as we go on into more and more studies and get better answers, which I hope happens rather than confusing everyone, I think we do need to continue with antenatal corticosteroids. And I'm hoping that the study which Prof. Jobe has suggested about reducing the dose of antenatal corticosteroids will bring about some light on the same. But the fact remains that till we find out whom really benefits from antenatal corticosteroids and who does not benefit, which unfortunately we find out postnatally, I suspect the procedure and the program continues on the constant use of antenatal corticosteroids in the appropriate high-risk population.
May I now invite Professor Alan Jobe for the final word on the topic before we close this session with the vote of thanks.
I agree with the final summary. I mean, I think antenatal steroids work, they have benefit, and so we should use them. But at the dosing should be probably the WHO dosing. I would prefer that than to the drug we're using in the US, actually. But if you can use beta-methazone phosphate and dose it according to the NIH protocol, that's probably to the WHO protocol, that's probably the right thing to do. So it's going to take a long time. I mean, this is just a example of bad medical progress. So this was a revolutionary discovery by Montligans, but nobody ever worked out how you should use this stuff. So we're using it, the rule in obstetrics is basically don't expose the fetus to any drug that's potentially harmful. So we're exposing these kids to a drug that's really potentially harmful. We know it's potentially harmful, and nobody ever did the studies to find out how to use it correctly. So it's a really bad demonstration about how not to advance care. So anyway, we're trying to do that. Hopefully we'll get it done.
Thank you so much, Professor Alan Jobe. Sir, it was such a thought-provoking day with such a wonderful session. Thanks to you, and also special thanks to Dr. Rama Chandramohan and Dr. Rahul Verma for such a long discussion, moderated very well. Thank you all. And before I invite the president of IAP Neonatology chapter, Dr. Naveen Bajaj, for the vote of thanks, I would thank all the audience and then invite you for the next upcoming session on 6th of August by Professor Saroj Saigal on the continuation of this, the long-term outcomes of prematurity. We are going to discuss prematurity in the month of August in the next few talks. So continue to join us. Thank you for such a wonderful response for this. May I now invite Prof. Dr. Naveen Bajaj, the president of IAP Neonatology chapter, for the vote of thanks. Dr. Bajaj.
Yeah, hi, good evening, everyone. And thank you. Special thanks to Professor Alan for giving us the time to our platform. And thank you very much, Dr. Rahul and Dr. Mohan. And Professor Alan actually has clarified many doubts and raised some of them also, and has provided many research questions for the futures for our neonatologists to help in solving it. Thank you. Thank you, everyone.
Thank you so much, sir. Professor Alan Jobe, shall we close the session?
Yes, it's time to call. I need to eat lunch.
Thank you, sir. Hope to catch up with you again sometime again, sir, in another session, sir. Thank you so much.
Thank you, sir.
Thank you.
Everyone, thank you.
Thank you. Thank you.
Bye.